Thank you very much. So for this last talk, we are going to discuss about pelvic oligometastasis in prostate cancer. This is the outline, and we are going to first discuss the natural history of pelvic metastasis. So if you look at this fantastic autopsy study with more than 1,500 patients included, and the post-mortem analysis of the distribution of metastasis clearly shows that most of the metastatic lymph nodes were either in the para-aortic nodes or in the pelvis. 80% in the para-aortic nodes, 55% in the pelvis. When looking at the metastatic bones in this series of post-mortem cadavers, you can see that also the ileum is more often involved than any other part of the bones in approximately 50% of the cases. So if you look at the distribution of distant metastasis when patients had pelvic or para-aortic nodes or other metastatic lesions, you can see that pelvic or para-aortic nodes lead to more distant metastasis in 84% of cases compared to 16% for patients with distant metastasis elsewhere, but not in the pelvic or para-aortic node. But these distant metastases were described as metachronous because simultaneous distant metastases were less frequent when patients had pelvic nodes only. If you look now at the patterns of failure after external beam radiotherapy, and if you look at this huge series from the Memorial Sloan Kettering Center, where high-risk patients are all treated with no whole pelvic radiotherapy. This is common at Memorial Sloan Kettering, prostate-only radiotherapy, even if you are at high risk. So with more than 2,500 of patients, approximately 9 years of median follow-up, you can see that most of the nodal failures occurred in the pelvis. And if you increase the upper limit of your pelvis to L4, L5, you can cover 95% of the sites of nodal failure in the pelvis. But keep in mind that the nodal failures were 2% only, and these patients had no whole pelvic radiotherapy. This is the reason why whole pelvic radiotherapy is really controversial. So if you look at the lymphatic path of the cancer cells when evaluated by sentinel nodes with SPECT or CT or MR, you can see, of course, that this upper limit of the pelvis should be increased to L4, L5, or even higher to include the para-aortic nodes. So this is a proposal for pelvic lymph node dissection, but for very high-risk patients, given the rates of para-aortic involvement, which could range between 10 and 15%, depending if it's evaluated with sentinel lymph nodes, MR, PET scanner, but it's around 10 and 15%. And we don't know if we need to enlarge the pelvis to the para-aortic nodes. This is currently assessed by the UK study named PEARLS, and the results are awaited. When looking now with more modern imaging with PET scanner, PSMA PET scanner for high-risk disease, you can see for sure that you increase the likelihood of bone metastasis detection or pelvic nodal detection. But look, the rate of pelvic nodes, even with a PET PSMA for high-risk disease, it's only 6%. So PET PSMA allowed to modify the strategy significantly by identifying metastatic lesions, but the nodes are really rare, in fact. So in this series, This is a German study which is really interesting to me because they looked at the patterns of failure after pelvic lymph node dissection on the left side of the slide, with or without pelvic radiotherapy. And on the right side, you can see, so on the left side, there is no pelvic radiotherapy, and on the right side, they had pelvic radiotherapy after an extended pelvic lymph node dissection. And you can see that the major pattern of failure is in para-aortic nodes. Otherwise, you can have diaphragmatic distant nodes or bone metastasis, but the most site of failure are the para-aortic nodes. In the post-op setting, this prospective study performed by the combined group of UCSF and UCLA, has assessed the distribution of metastasis, and you can see that they observed 17% of pelvic nodes in the situation of a rising PSA, which allow to propose a local treatment or a combination treatment with ADT in around 76% of the patients. So after a PSMA-guided treatment of lymph node metastasis in the pelvis or bone metastasis, and you have the distribution of the bone metastasis, whether if they are in the pelvis or extra pelvis, you can see how the patients fail after a PSMA-guided treatment. And that's really interesting. And I would summarize this diagram by some trends, which could be summarized by pelvic nodes more often recur to distant nodes. Pelvic bones more often recur to distant nodes or bone, more than pelvic bones. Distant nodes go more to distant nodes. And prostate bed more often goes to bones. Let's now discuss about synchronous pelvic nodal micrometastasis and the role of whole pelvic radiotherapy. So, in the context of prostate radiotherapy and in the post-operative setting, so you know the POP-RT study now, which was recently published in the JCO. It was in 2022, correct, Maria? She knows that. So this is the first study which showed a significant benefit in metastasis-free survival. You know that before this study, it was really controversial because at first time, the RTOG was positive. With a longer follow-up, it became negative. The French study was negative, but patients were at a lesser risk, and it was a mini pelvis. So we didn't know really if it was beneficial to deliver whole pelvic radiotherapy. And now, with this monocentric study from India, Tata Memorial Center, all high-risk patients with a Roche score, so probability to have a lymph node involvement, micrometastatic lymph node involvement of 20% of higher were included, and all the patients had to have a negative PSMA PET. And they observed a benefit in metastasis-free survival for the first time in a phase 3 trial in this study. The other study in the post-operative setting is the SPORT trial, RTOG 0534. In this study, the endpoint was not metastasis-free survival. It was biochemical-free survival, and they found a significant advantage of delivering 6 months of ADT and of delivering 6 months of ADT plus whole pelvic nodal radiotherapy to prostate bed radiotherapy. And you can see it's not metastasis-free survival. It's crude number of metastases observed, but there is also a difference in favor of whole pelvic radiotherapy with a lower number of metastatic failures, even if it's significant, but it's more than a trend, p.043. So what are the patients who most benefit from whole pelvic radiotherapy in both studies. In the POP-RT study, if you look, it's a forest plot with all the statistical limits of the interpretation you can give to a forest plot. But if you look, the patients who have the higher benefit from whole pelvic radiotherapy. So at inclusion, they had to have at least 20% risk. And in fact, the patients who most benefit had more than 40%. So it's no more high-risk patients, and this is probably the reason why it was still controversial for decades, but it's beneficial for very high-risk disease. If you look at the post-op setting and the forest plot of the SPORT trial, when compared to prostate bed radiotherapy alone, adding 6 months of ADT benefit for all the subgroup of the patients. Adding 6 months of ADT plus whole pelvic nodal radiotherapy benefit to all the subgroup of the patients. But if you compare the two groups of patients who had 6 months of ADT, it becomes really difficult to identify who benefit from whole pelvic nodal radiotherapy. So these patients should have mostly ADT. And if at very, very high risk, with high-risk features, whole pelvic nodal radiotherapy could be discussed. So let's discuss now about timing of ADT, which is a hot-burning topic, very new for the radiation oncologist, and new hormonal therapy. RTOG 9413 study has a very, very long follow-up. So more than 1,300 patients included, with a median follow-up of roughly 9 years. And the finding with this long follow-up is amazing, because they found with a longer follow-up that there could be an interaction between ADT and the volume of radiotherapy, timing of ADT and volume. And what they found is that if you deliver whole pelvic nodal radiotherapy with neoadjuvant radiotherapy, you significantly improve progression-free survival compared to adjuvant ADT. At the opposite, if you do not deliver whole pelvic nodal radiotherapy, neoadjuvant ADT is not beneficial. And this is mind-boggling. But it has to be considered now with the patient. This has been confirmed by a meta-analysis from the RTOG, ORTC, and TRUG studies on more than 7,000 of patients, which found exactly the same results, this time on distant metastasis. So this is a brand new result which need to be used in a daily routine practice, I think. Should we add to those patients with a high risk of pelvic nodal metastasis or bone metastasis new androgen receptor therapy? You know the results of the STAMPEDE trial, which shows that adding 2 years of abiraterone with 3 years of ADT significantly increase the metastasis-free survival and the overall survival. If you look at the patients included, so either there were node positive in the pelvis, it stands for 41% of the patient. Otherwise, they had to be at very high risk with at least 2 high-risk features amongst T3, T4, Gleason 8 or higher, and PSA at 40 at least. And if you look at the patient, the subgroup in the STAMPEDE trial, the subgroup of patients with only node positive in the pelvis, you can see that this patient in the subgroup analysis benefit from abiraterone, and I believe that now you can add this therapy to ADT. If you look at patients with oligometastatic disease in the pelvis, in the bone, so this is on the right side of the slide, you can see that These patients, we know now with the STAMPEDE trial that prostate radiotherapy is beneficial for low-volume metastatic disease, but is it beneficial if you had pelvic nodes? We don't know, because in the subgroup analysis, the results are negative, but it was prostate-only radiotherapy. And if we don't know if it would have been positive if we had delivered whole pelvic nodal radiotherapy. And that's a true question. Metachronous pelvic nodal metastasis and role of whole pelvic radiotherapy. So that means salvage nodal pelvic radiotherapy for nodal failure. In France, we had this phase 2 trial called JETUG P07 or Oligopelvis, which showed that the prognosis of those patients who had metachronous pelvic nodal failure is worse than patients with synchronous node-positive disease. With a median follow-up of 6 years, the 5-year progression-free survival is 39% only, and most of the patients underwent, at the end, palliative ADT, lifelong. With my group, we tried to compare, because when you have a patient with a nodal failure on PET PSMA, sometimes you want to believe that you can cure the patient only with SBRT. And just by targeting the node positive on PET, you could cure the patients. So in the first paper, we showed a significant difference in favor of extended field, including elective nodal irradiation, even if a patient has a single node. But in the long term, with a longer follow-up, we didn't find any difference in metastasis-free survival or biochemical-free survival or cancer-specific survival, but a difference in the interval time before starting lifelong ADT, palliative ADT, with no difference in acute or late toxicity. So a focal treatment with SBRT for those patients with pelvic nodal failure, or an extended treatment with elective nodal irradiation, even if you have a single node, is really debatable. And we have published with Macroach some recommendations. You can see this is a proposal, because we don't know how to select the patients for salvage elective nodal irradiation with a boost on the node, or focal SBRT for a single node. And we proposed some indications. Patients had to have a rising PSA and or PSA-DT less of 6 months, and or multiple nodes, and or lymph node risk at more than 15% to be selected for extended field radiotherapy with elective nodal irradiations. You have the pros, you have the cons. In this situation, the recommendation is to deliver concomitant long-term hormonal therapy, but you can discuss short-term depending on the number of high-risk features. And at the opposite, if the patient has favorable features, rising PSA less than 10, and PSA doubling time over 6 months, a single node, a lymph node risk of less than 50%, a focal single node SBRT could be proposed. Pelvic nodal or pelvic bone oligometastasis. Is there a difference in prognosis? So if you look at the patterns of failure in this series of patients treated to the bones or to the nodes with SBRT, metastasis-directed therapy, you can see that patients who were treated to the bone mostly recur in the bones, 86.5%. Sorry, but I have no screen. And if they had initially nodes, they mostly recur in the nodes in 2/3 of the patients, with very few patients who had concomitant bone and node recurrences. This retrospective series from the group of Matthias Guckenberger at the University of Zurich has tried to assess the difference in prognosis between patients with oligopelvic nodes or oligometastatic bones. And they found a huge difference in favor of oligometastatic pelvic nodes when compared to any other metastasis in the body, even at the oligometastatic state. So this is really strong, and this shows clearly that these patients had a favorable prognosis compared to patients with bone, even if oligometastatic. Thank you. So in conclusion, I would say that we must keep in mind that pelvic nodal metastases or failures are rare with modern imaging, between 2 and 17%. Whole pelvic nodal radiotherapy is beneficial if very high-risk features, Roche score at least of 20%, at least, maybe 13% when looking at the 13 or 40% when looking at the subgroup analysis of the POP-RT study, or when looking at the results of retrospective studies suggesting that patients with at least 35% would benefit. So the cutoff is around 30%, I guess. In the post-op setting for patients with a PSA higher than 0.5, whole pelvic nodal radiotherapy should be discussed, but it should be balanced with the toxicity of whole pelvic nodal radiotherapy because those patients benefit mostly from ADT. This is level 1 evidence of ADT. Starting 2 months before whole pelvic nodal radiotherapy may provide a better outcome. Level 1 evidence from a randomized study and the meta-analysis. Intensification with RP is beneficial for very high-risk node negative or node positive, but is it still better when whole pelvic nodal radiotherapy is delivered? We don't know. Level 2 evidence. Metachronous nodal oligometastasis have a worse prognosis, but in selected patients, metastasis-directed therapy may be discussed with the patient, balancing benefits and risk of salvage whole pelvic radiotherapy and ADT. Level 2 evidence. And finally, oligopelvic, it seems that oligopelvic nodes get better outcome than oligopelvic nodes, but this is level 3 evidence. Thank you for your attention.